Welcome, everybody. Today, we have the pleasure to have with us Dr. Rafal Machowicz from the Department of Hematology, Transplantation, and Internal Medicine of the Medical University of Warsaw in Poland. Rafal, it's a pleasure to have you with us. How are you today?
Yes, it's a pleasure and honor to be with you. Thank you very much for your invitation. It's great to be with you.
Thank you very much for accepting. So today we are talking about your research entitled Allogeneic Hematopoietic Stem Cell Transplantation for Adult HLH, a retrospective study by the Chronic Malignancies and Inborn Error Working Parties of the EBMT. So first of all, I think we should define what is HLH, right? Why it's so important to have clinical acumen and promptly recognize this condition.
Yes, so HLH, it's abbreviation for Hemophagocytic lymphohistiocytosis. So I prefer the abbreviated name because some people
exactly
have real problems with pronunciation and remembering the full name. It's one of cytokine storm syndromes, which is not very well defined zone of hyperinflammatory disorders. Usually we use HLH 2004 criteria, at least 5 out of 8 of them to define it. For diagnosis, but there are also some other diagnostic systems like H-score, for example, or OHY, which was published this year. But basically, HLH is hyperinflammation, which doesn't stop by itself until it kills a patient, or we diagnose it and treat it. So the diagnosis, as you said, is very, very important. And as a very large inflammation, it doesn't have any characteristic pathognomonic features. It's growing very large inflammatory reaction. And among criteria are, of course, fever, cytopenias, splenomegaly, hyperferritinemia. This can be characteristic because as you deal with patients with iron deficiency, it's like several nanograms per milliliter. In inflammation, of course, it's several hundred, several thousand, but in HLH, you can have several dozen thousand or even 100 or 200,000. Then it will be quite characteristic for HLH, but of course, different states like acute liver failure can also lead to such high hyperferritinemia. But this is the most characteristic part. But you have to also remember that there are some patients with lower ferritin who also have HLH. So hyperferritinemia, hypertriglyceridemia, hypofibrinogenemia, so high triglycerides, low fibrinogen, and if I didn't omit, and hemophagocytosis. This is important thing to stop a second, because the other name for HLH is hemophagocytic syndrome. It's not synonymous. Some people use it in a bit different meanings, but it's also a name of such disorder. And hemophagocytosis is a phenomenon when macrophages engulf healthy bone marrow cells because they are overactivated in this hyperinflammation. But it can also happen in different states, like even after blood transfusion in some infections like leishmania, also in some other prolonged inflammations, including sepsis. That's why it's not pathognomonic. Like excluding HLH because there is no hemophagocytosis would be a grave error because there can be other criteria fulfilled. And diagnosing HLH because somebody has hemophagocytosis and some symptoms, so hemophagocytosis plus symptoms is hemophagocytic syndrome, not really, not that easy. It could be also a mistake. So hemophagocytosis, and then there are two criteria which are not widely available. Soluble receptor for interleukin-2, so SCD25, and activity of NK cells. So these are for more specialized centers, but they are included in diagnostic criteria. So this is how you diagnose, and basically it describes a lot of features of HLH.
Thank you. Yeah, I vividly remember the case of a kid who actually had this characteristic bone marrow feature, which is like the emperipolysis, right? Like the macrophage that embrace the still vital cell in the cytoplasm. And also, yes, important, as you say, that these two minor criteria that are important, especially for the familiar ones, in particular the granulation, right?
Mm-hmm.
So can you guide us through the design of your study? What was the impetus behind your idea, and which were the aims?
Mm-hmm. So impetus was that I realized that there is no such analysis, and I was interested how does allogeneic stem cell transplantation work in adults. Of course, a little bit of history. Even though the very first patients were diagnosed with HLH, or like it was called a bit differently, they were adults. Mostly this disease is diagnosed in children. Oh, sorry, it's not disease. This is important thing. It's a syndrome because it can be triggered by different triggering factors. Usually infections, malignancies, or autoimmune diseases or autoinflammatory diseases. And then in this setting, it's called MAS, macrophage activation syndrome. But there are also some other subdefinitions for MAS. But let's stick to this one. So this is not a disease, but a syndrome, and also a lot of things in treatment and prognosis depends on the triggering factor. So first, it was more widely diagnosed in children, owing to fundamental works by Professor Grita-Janka. And while it was, and of course, those children had, yes, why do people get such reaction? So in children, frequently there is an error in, like inborn error, in cytotoxic granule pathway, meaning that NK cells and cytotoxic lymphocytes cannot kill target cells because the cytotoxic granules don't work. And of course, HLH is triggered by one of the very first infections in such child. Then, of course, you cannot do much better than somehow stop it and then perform allogeneic stem cell transplantation, because without new properly working immune system, this child will develop HLH with the next infection and the next infection, and it cannot go on like this. So transplantation and diagnosis of HLH, it was quite known in children, whereas in adults, HLH was much more underdiagnosed, and infections which cause HLH in adults, it can be EBV or CMV virus B19, usually in young adults. And then you've got a lot of malignancies and autoimmune diseases or autoinflammatory disorders. So then I was interested, what are the outcomes of adults with HLH who are transplanted? And I thought maybe, like in Europe, EBMT is the organization who has a lot of data. And I'd like to thank Professor Nicholas Kreger, who was open to this idea, and which there was a lot of problems with identifying those patients. Finally, we found them. Quite reasonable group of 87 adult patients. I mean, it's the largest group that was published. This is main strength of this manuscript. But of course, the data is retrospective, as usually in BMT. We don't have all the precise data. Yes, so my impetus was to check what's going on, what is the prognosis in adults.
I see. So you already started like by describing the study cohort characteristics. So was the clinical picture that you briefly summarized when we were talking about the diagnostic criteria the same? Did you find an overlap of characteristics also in adult? Which were like the main characteristic that popped up from like this detailed analysis?
Yes, so we had basic data from standard questionnaires that standard data for BMT patients, and of course they are not so much HLH oriented. So we designed an HLH oriented questionnaire which was distributed to centers, and we got responses for 33 patients. Then we've made sub-analysis that there is no significant difference in this subgroup and the other patients. So they are somehow representative for this group. And it really confirmed a picture of HLH with fever diagnosis, hyperferritinemia, and hemophagocytosis. So it was so we are quite sure that they were in whole patients with typical HLH, but of course the diagnosis was made by the centers, and they decided how to report their data. So this is
it was anyway, like the clinical picture of presentation was consistent with the diagnosis of HLH. And now let's talk also about the results of your analysis, specifically the outcomes, which are obviously the main aims of your study. Did you find any major factor impacting the survival outcomes of this patient, like for example, reduced intensity versus myeloablative conditioning regimens or any others?
So in a little bit of background, in children, like the largest change in survival and in treatment was introducing etoposide in treatment of HLH, and then there were two protocols very similar, HLH 94 and HLH 2004, and they, as we've discussed before, included transplant at the end of treatment of such child. Usually myeloablative conditioning with including also etoposide, but there was high non-relapse mortality. So a lot of this were attributed to conditioning toxicity, and there were successful attempts with reduced intensity, because if you consider HLH as immune defect, you don't have to really fight the last remaining resistant AML cell. You need to get reasonably working immune system. And as very nice work by Bernd Hartz from Keilenberg's group show, that if you have at least 20–30% chimerism, so not so high, like the risk of relapse is reasonably low. So reduced intensity was an interesting option for children. And Rebecca Marsh shown very nice data where reduced intensity had survival of 90%, whereas for myeloablative conditioning it was much lower. So when I saw the data, like my the very first look, like my the thing that really astonished me was that not only there is no significant difference between reduced and myeloablative conditioning in adults, but those Kaplan-Meier curves are really superimposed. It's like one line. So I was really surprised because I thought, like, we had also some young adults, and reduced intensity is also better in older patients. So it could be like this, but it was, or maybe there would be a trend tendency, but the group is not so big, so maybe the small difference will be non-significant. But there was virtually no difference. So this was a big surprise for me, because at that time there was tendency to move towards reduced intensity because pediatric results were very promising, and there was no good no large groups of adults. So reduced intensity seemed very appealing. Now the situation changed a bit, because also pediatric results in reduced intensity are not so great, let's say. So there are many attempts how to optimize. So so this is how the field is going on now. So with myeloablative and reduced, there was no difference, and it was a main finding, because based on pediatric data, you rather shouldn't perform myeloablative. And based on our data, you can, if you have some preference, why not? And what we found was significant for survival. It was age, not surprisingly. So usually younger patients have better prognosis, and here it was also visible. Of course, there was also more patients with primary HLH among this group. And here is another, like, a small box with another clinical pair. What's primary, what's secondary HLH? These names are not very correct, but they are somehow informative. So primary HLH is when you have a mutation and it's genetically based. Let's say, so then transplant is indicated. And secondary, but it's not so primary when you've got young adult, and even in a child, it's triggered by infection. So even in very small toddler, it's also secondary to that infection, but of course predisposition is the key. Whereas secondary is when you don't have a real genetic cause, and the trigger itself is very strong. Like, for example, lymphoma, that someone had all the infections, including EBV, and when he was 50, he got lymphoma. And this triggered HLH because it was such a strong trigger. Yes, so we had this, so younger adults would be more fit for transplant, of course, and for complications. And also maybe a bit more primary cases which have better prognosis. But what's important in our study, we didn't have, we had hardly any patients with malignancy. There were 3 patients out of 87 with some malignancies. Like, one was diagnosed, it was transplanted due to EBV, HLH, and then he had relapse. And when he died, they found that it was from autopsy, etc. So this group didn't contain patients with malignancy-associated HLH.
So we cannot draw a conclusion, of course, for those. But instead, what about relapses? Because I saw, like, from your curves that, like, after 2 years, the relapse rate goes at a plateau. Seems like if patient passes by these 2 years cutoff, they will do good, right?
Yes, and this is good information, because like, overall survival was about 44%, what is worse than in children. but like good information is that allogeneic stem cell transplantation can provide cure for this disorder, that at some point risk of relapse is low, and of course the relapses were like early and then they were going down. So at some point patients can be cured. This is good information.
Correct. And what can you comment on the difference as to the outcomes of primary versus secondary? You already said something like age matters, of course, but is this difference perhaps driven by the high frequency of patients that are transplanted somehow quicker in the primary disorder versus the secondary disorder, which somehow like is more difficult to be diagnosed, or because it requires that the clinician suspect the HLH and like perform all sorts of like clinical and bone marrow evaluation. So perhaps like also the evidence of a primary disorder makes the decision to go and recur to transplant way more easy, quick, and therefore beneficial for the patient.
Yes, you're totally right. Because we didn't say about indications for transplant, and this is the important part. Because in primary HLH, especially in children, as we discussed, this is the best only option. Okay, but in adults, you have to check like what's the strength of the trigger, and do you have any predisposition? So if you have like 19-year-old with EBV triggered HLH, and you find some imported mutation, of course, like adults with HLH have survived at least 18 years, so they don't have very like strong mutations which make some protein to have no function, but you find some mutations, and then the decision is quite obvious. So the patient is young, he has, and probably he would be in good clinical shape and in remission. For those without mutation, for secondary HLH, transplant is indicated for patients with relapsed, refractory, or CNS disease. So the same, even young patient, but without mutation in one of those genes, or gene was not sequenced, or something like this, would just be in remission, and he can relapse with HLH, and then, or he can be refractory from the beginning. Of course, some genetic ones can also be refractory, but those who are with secondary and everything went fine, they will rather not be transplanted. But those with secondary and some problems, large problems like refractory disease, they would go to transplant, of course, not in perfect shape because they had refractory disease, and it can affect overall outcome of the transplant. So this is, it was also observed in children that patients with familial disease have better outcome. Here we had, like we've shown it for PFS, but not for overall survival, that there was a tendency. So this is an important factor. Why did the patient, what were the indications for the transplant?
Correct. But like, since we are somehow at the interface of a disorder that may be triggered either by inherited or acquired factors, how do you deal with that in adults, specifically in adult cases? Because is testing for the for germline HLA related variants also indicated for older patients? Is there an age cutoff, or does also their presence and thereby the definition of these familiar cases, as we say, then is useful for the decision to go to transplant, right? So how do you deal with like the genetic testing? Do you test all, even if they are like older?
So it depends on the availability of tests, but also, like, again, if you've got a 19-year-old with EBV, you would rather go for testing. If you've got, like, okay, 70-year-old, probably wouldn't transplant, but like a 55-year-old, to make it very, very good candidate for transplant. And with a lymphoma, as long as this patient would be in remission of lymphoma and doesn't get a relapse or another lymphoma or another malignancy, probably he should be fine.
Okay.
So you wouldn't go for transplant, and then you can look for genetic factors if you want. I would say that it doesn't hurt, but it might, because it's a bit like testing, over testing can lead to different problems. Like when you find some hypomorphic mutations or even polymorphisms in one of HLH related genes, or maybe it's heterozygous, then you're starting to be uneasy, and then it can trigger a decision of transplant, which might be too early. Of course, you don't know in every patient. You cannot save the game and check what would happen. Maybe without the transplant, he would relapse very badly in several months in HLH that you cannot control. Of course, it can happen. But of course, we all know what can happen with allogeneic stem cell transplantation when it doesn't go as smoothly as we would like. So this is also a risk for patient. And for example, like easy example is perforin A91B mutated, like polymorphism, not a mutation, which is in like about 8-9% of Caucasian population, and it has some impact on activity of this perforin protein, and it was associated with some predispositions to HLH. But if it's there, it's very, very slight. Let's say like there was very nice study by Ilya Voskoboing. They got data from some cardiology cohort of 13,000 patients. So in cardiology, they've got much larger cohorts, and they checked what's the frequency of the allele of this perforin allele in this population. Because if homozygotes are eliminated due to frequent HLH or lymphomas, or there should be less homozygotes in population of around 70-year-olds. And it was, as Hardy-Weinberg law would say, like it was normal. So it's not a little mutation. It's like you can say, if you've got a patient who has this polymorphism, to say, okay, it might have contributed, but of course it's not an indication for transplant.
Correct.
And then
as you say, it's a polymorphism, so it should be regarded as such, right? Especially when we talk about inherited traits, we always have to be very careful for like genetic counseling, because this might also affect the choice of the donors within the family, right? So
yes, so it's also important. Yes, and there is another important thing. Like one is, okay, not to choose a sibling donor with same mutation, because it wouldn't make sense. And on the other hand, there is a question about this sibling who didn't develop HLH, even though it has the same mutation, because there is this trigger. So this primary is also a bit secondary. This child didn't have contact, or the contact was smaller with same infectious trigger, and didn't develop HLH so far. And there was interesting work, but retrospective, that children who are transplanted upfront before they develop HLH had better prognosis than those who are waiting for it to come and then to have transplant in remission. Of course, in adults, we don't have such problems because our patients are getting only older. But in children, if you have like 1-year-old or 2-year-old, like the child is developing, so it's better, as I understand, to have a transplant a bit later. That's why it's tempting to wait, and this is the important decision about upfront transplant, because of course those mutations which cause HLH in early childhood are very strong.
Predisposing factors, yeah.
Yes.
So last question that is more like a personal curiosity. Why did you decide to focus on HLH? Is this like a particular interest of yours? Is there any particular reason for that?
Yes, so I'm interested in HLH for like most of my medical career as a doctor, and I picked this from my mentor, Professor Viktor Jędrzejczak. Viktor Jędrzejczak was head of my department, and he was among the first ones to diagnose HLH in adults, because after work of Professor Janka, it was quite known in pediatric community. It's one of, and it's still a bit like this, that pediatric hematologists, hemato-oncologists know, okay, HLH, yes, we know it. It's quite rare, but it's one of our less frequently found diseases, and they don't have any problems with acknowledging that it exists. And in adults, it wasn't known. So he found that in a teenager that there might be some syndrome, and then he started to spread the word, and I took it from him, this interest, and there's a lot of things to be still to be done. A lot of discussions. I mean, Histiocyte Society in HLH steering committee. So there is a lot of work.
Nice, and it's also important to know for our trainees that like sometimes passion can be relay like the Olympic torch from our mentors to us, right? So it's like also nice, like growing within the same passion and being like embraced by the same passion for something that is also characterizing the career of your mentors.
And for me, it was like very important in this that we didn't live in those times. But for example, when there was hardly any cure for anything, for any disease, and it was like modern time, like 50 years ago, like the Beatles were playing, and people were going to the moon, and most of malignancies you couldn't treat them. And then there was a treatment which provided like 50% survival. It was, wow, we can save every second, like it was. And now we don't observe such, now we are observing small steps from 70 to 75%. But what is very, very good, of course, and we are in much better position. But here for me, it was, there are people, if we don't diagnose it, they really die. And they have 0% chance out of mechanism of this disease. And if we simply diagnose it, start some steroids, etoposide, like inexpensive drugs, they've got around 50%. Wow, and I couldn't really stand that there are people who have no chance, and you can give them so a lot of popularization also, and there is also another important thing of differentiating HLH and sepsis, because there is a huge overlap, like among thousands patients with HLH, there are patients, single patients with HLH who could be cured, and even with the best intensive care, they cannot be cured. So this is another important subject.
Well, that's amazing, and thank you for bringing up these issues and talking about HLH with us. I'm sure like that everybody will appreciate them, and thank you again for accepting our invitation.
Thank you very much. I hope that now people will be more aware of HLH, and this is my mission. And can I make make a short invitation. I would like to invite everyone in a few weeks. There will be a European Hematology Association Congress in Vienna. And just before, there is a YoungEHA research meeting focused on research and young scientists. So also clinical scientists. So you're welcome, and you're also invited to follow the pages of YoungEHA committee, which I'm a member of. So stay tuned.
And it's nice to have you in from the YoungEHA committee with us of the EBMT trainee committee, which we
cooperate.
Yes, we cooperate, and we also invite you to follow us on our social media, and we're going to have our trainee day that was for the first time done this year in virtually. It was supposed to be Prague, and hopefully next year we will have it in Paris too. So nice to collaborate between our association.
Yes, so thank you very much for this.
Thank you so much.
Opportunity to spread the word. Thank you.
Thank you.